All right. Good morning, everyone, or good afternoon, depending your time zone. Thank you for joining today's call. Please note that today's convening is being recorded. Anything said or sent in the chat during this meeting may be a part of the public record. My name is Marilyn Johnson. Joining me today are Monica and Rachel LaFlame from HMA, and we are with Health Management Associates. Health Management Associates is a leading independent national research and consulting firm that focuses on improving the administration and delivery of public health, healthcare, and social services programs. Some of you may be very familiar, but HMA is supporting the Mississippi Department of Mental Health in its efforts to enhance the state crisis response system by providing monthly online crisis response trainings. So each community across Mississippi, across the state experiences crisis response differently based on geography, relationships, and available resources. So the purpose of today's call or today's training is just to explore the differences and look at how crisis teams and partners can strengthen coordination, work better together, have better engagement in ways that reflect the needs of local communities. So we'll use some Mississippi data, give some real life examples, share some lived experience from our lovely presenters today and throughout the session so that the conversation stays connected to what people are actually seeing across the field, across what we do, live, and breathe every day in the work that we do. All right, let me switch things a little. Next slide, please. So I just want to take a moment to kind of level set what we're going to do today in this session, or what we're trying to do today in this session. Start by talking about some of the statewide community level challenges that affect crisis response in Mississippi. And when I say that, I really mean how capacity, coordination, and access look different depending on where you're sitting in the state, depending on where you live, where you work, all of those things. So from there, we'll look at a few examples of strategies and partnerships that are working, not because they're perfect, because nothing is perfect, but because they're helping move the needle in real ways. And then the goal is to bring it back to you. As we go, I'd encourage you to think about how your role, your region, and what parts of this feel familiar or challenging where you work. So this isn't just about information, it's more about how you apply it in ways that make sense locally to our state. Next slide. Identifying statewide and community level challenges. So our first section or first few slides really talk about naming the challenges honestly. So when we talk about crisis response in Mississippi, there isn't one single experience. What works in one county looks very different from what's in another county, and a lot of that comes down to geography, workforce, transportation, relationships, etc. So as we walk through this, I want to be clear that we're not pointing fingers or looking for perfection. We're just trying to surface the patterns that show up across the state and where communities are feeling the strain the most. So my hope is that as you listen and as you engage, you'll hear pieces of your own experiences reflected here. So why the conversation matters. So before we go into a lot of the details, I want to pause for a moment on why the conversation matters here in Mississippi. One thing that's really important to understand is that our communities experience crisis response very different across the state. Communities have their own strengths, their own needs, and geography plays a big role in how and when people can access help. Local relationships matter a lot here. In many places, coordination during a crisis depends on trust that's built over time before providers, law enforcement, faith leaders, and community partners. Those are the people, often in communities who will see the crisis first. And every county is working with a different set of realities and resources. What's available in one area may not exist in another. What works in Quitman County does not work in Hinds County. So it's just very, very different for us here in the state. I also want to acknowledge something that's unique to Mississippi. It's our culture, our traditions, the way we relate to one another, um, how they really shape how people seek help and how support often shows up. And so sometimes that understanding only comes from living and working in the state. So the goal today isn't to compare communities and place blame or anything of that nature. It's just really to recognize the differences. Honestly, so we can think about how to create more consistent crisis response experiences across the state while still respecting what makes each community its own. Next slide. We'll look at a little bit of data here. So just to put some scale around why this work matters, it helps to look briefly at what the data is telling us. Nationally, suicide remains a serious issue, with one person in the United States dying by suicide about every 11 minutes. And when we look at Mississippi, the impact is very real. And according to the 988 Study Commission report, more than 400 lives were lost to suicide in the last year, and over 100,000 adults reported having thoughts of suicide. And so we also know that, thousands of Mississippians are living with mental health condition, including serious mental illnesses. The CDC has reported an increase in Mississippi's suicide rate in recent years, and suicide is now one of the leading causes of death for young people in our state. And so I'm not going to read through all the numbers. You can see them here, but they help ground the conversation behind every statistic is a person. It's a family, it's a community. And that's why the work we're doing across the state matters and why it's so important for this conversation today. Next slide. So as we think about crisis response across Mississippi, there are a few big picture challenges that come up again and again, no matter which part of the state we're talking about. One of those is capacity. So that's really about whether crisis teams have enough staff, time, resources to meet the level of demand they're seeing, especially when teams are covering multiple counties or large geographic areas. Another challenge is coordination. Crisis response almost always involves more than one organization, partnership, whether it's 988, mobile crisis teams, law enforcement, hospitals, courts, or community partners. How well these partners communicate and work together has a direct impact on how smoothly a response goes. And lastly, or thirdly, the challenge is access. Even when services exist, how easily someone can reach crisis response matters. How easily someone can reach crisis response matters, and that can be influenced by geography, transportation, hours of operation, or simply knowing how to call and what to expect. So these three areas are all connected. Capacity affects coordination, coordination affects access, and access affects the outcomes. So as we move through the next few slides, and examples of this framework can help you think about where the pressure points are in your own community and which of these challenges feels most familiar where you work. Next slide. So some of the statewide factors that shape service delivery. When we talk about how crisis services actually operate across Mississippi, there are a few statewide factors that shape what that looks like today. Geography for our state is one of the biggest. 65% of Mississippi's 82 counties are rural, and that has a real impact on response times, travel distances, and how quickly someone can be reached in a crisis. What feels like a short delay in an urban area can look very different when teams are convening multiple counties along stretches of highway. And we know for our state, that's typical. It's not abnormal. It's not a part of our day to day. It's actually the reality of how we shape our services. Workforce is another major factor. About 80% of Mississippians live in health professional shortage areas. And on an average, there's roughly one mental health professional for every 500 and 90 residents. Um, that means fewer residents providers carrying heavier caseloads and responding to crisis across larger service areas. Transportation also affects access in a variable way. In many counties, there's no public transit option at all, which can limit how people get to services and how follow-up care happens after an initial crisis. And collaboration looks different depending on where you are and where you live. Available partners vary by county, and crisis response often relies heavily on local relationships and most of the times informal coordination. So, all of these factors shape capacity, response time, and how follow up across the state happens. So, they are all a part of the reality that providers and partners and our partners are working with every day. Next slide. So, on one of the challenges that consistently comes up in conversations about crisis response is the availability of behavioral health workforce, especially in rural Mississippi. So, when you look at the data across providers, including psychiatrists, psychologists, nurse practitioners, social workers, and counselors, Mississippi has fewer providers per population compared to national average. And so that's a unique thing for any state, in my opinion. We often have to shape our services when we're open, when we're closed, what we provide based on the provider that's available or not available. So that gap becomes even more pronounced in rural areas where a small number of providers are often serving larger geographic regions. This affects how quickly crisis teams can respond and how far they have to travel and how much ongoing follow-up support is realistically available. It also places additional strain on the providers who are in the system, many of whom are covering multiple roles or responding to crisis with limited backup. For many communities, this workforce reality directly shapes the crisis experience. Understanding that context helps explain why coordination, communication, and realistic expectations are so important when we talk about strengthening the crisis response statewide. Next slide. Barriers in rural and urban Mississippi communities. So when we talk about barriers to crisis response, what we see across tends to follow some very consistent patterns. In rural communities, the barriers often show up through long travel distances for mobile crisis teams and for follow-up care. Many areas have limited crisis facilities within driving distance, little to no public transportation, and teams that are covering multiple counties at the same time. That stretches capacity and affects how quickly help can arrive. In some of the more urban parts of our state, the challenges look a little different. There are often higher call volumes and greater service demand. Co-response with law enforcement happens a little more frequently, and hospital emergency departments can become, overwhelmed, which can place delays to people receiving treatment. So urban areas also tend to see more complex social needs, including housing instability, substance use, and repeat crisis. So while the barriers look different, both rural and urban settings experience coordination challenges, especially when teams are responsible for multiple jurisdictions or systems that don't always communicate smoothly. And these patterns often reflect what we see statewide, according to several reports by the Department of Mental Health, mobile crisis staffing models, and et cetera. So I want you to think about which of these barriers feels most familiar in your own community and how it connects back to capacity coordination and access. And the next slide. Okay, so now let's take a brief pause and bring your own experience into the conversation. So you've heard some of the statewide patterns, but every community has its own realities. And so what I'd like for you to think about is what feels most challenging where you work, It might line up closely with what we just talked about, or it may look very different. The question here is simply, what are the unique challenges in your community when it comes to crisis response? No right or wrong answer. The goal is just to hear from each other and start noticing both the similarities, the differences across regions. And this also helps set up the next part of our discussion where we look at some of how the system is designed to work together. So if you'll just take a moment and in the chat box, you can start to respond to the question. So, what are some of the unique challenges in your community? I see short-staffed as being one, transportation, of course, and the number of providers across the state, transportation, another one, unintentional adversaries, needing more providers for families, yeah, follow-up care after crisis day. Homelessness in Biloxi is big, and the majority of them have mental health issues with no access to care. Transportation, long wait times, parental involvement. Yep. Actually going out when the crisis does call for it needs to take place. Not enough resources. And all of these really kind of back up some of the things that we've discussed. But because these are things that you do every day, you witness, you explore, they're a part of your day to day. There are other things that come up. So I want to thank everyone for sharing, and thank you for being open and willing to share. And we'll continue to move through to the next part of the presentation. All right, so let me get back to where I was. I'm sorry. Miss, um, so before we go any further, I want to take a moment to ground us in the crisis continuum of care. Most of us, most of this will feel very familiar to you, and that's okay. The key point here is that crisis response is a system. It's not a single touch point. It starts with someone to contact, like 988, Lifeline, or other behavioral health lines. From there, it moves to someone to respond to, including mobile crisis and outreach services. And in some situations, people need somewhere to go, a safe place, such as crisis stabilization services or emergency care. And throughout the process, connection matters, making sure people are linked to ongoing support and follow up. And so I won't walk through each and every piece because I'm sure you've seen this before. If not, we do have some resources available at the end, and you'll be able to kind of research these a bit. But what matters most is how these components connect to one another. Communication and coordination across this continuum are what makes crisis response work, especially in communities where resources are limited or stretched. Next slide. And so the slide is a reminder that Mississippi's crisis system didn't appear overnight, right? It has been built over time through a series of intentional steps. And over the years, the state has expanded crisis stabilization units, peer support, crisis intervention teams, and mobile crisis response. Most recently, the launch of 988 and related legislation strengthen how people help and coordinate at the state and local levels. Each of these milestones reflects progress, but they also add complexity. And as the system grows, coordination across partners becomes even more important. So, looking at the timeline helps frame where we are today. It shows how far Mississippi has come, and it sets the stage for ongoing work of strengthening communication, partnerships, and follow up across the continuum. Next slide. So at this point, we spent time talking about challenges, barriers, and because those things are very real in the context of our state. The next section shifts the focus a bit, and the goal here is to recognize what's working well across the state and the partnerships and strategies that are helping strengthen crisis response. Mississippi has made meaningful progress in several areas, often by relying on collaboration, creativity, strong local relationships. And as we walk through these examples, I want you to listen for things that feel familiar in your own work and think about where you see success happening in your current region. Next slide. So one thing that's important to acknowledge in Mississippi has real strengths in its crisis continuum of care. Communities are doing a lot with limited resources, and those efforts make a difference. We see strong statewide responsiveness, including a very high in-state answer rate for 988 calls. That means people who reach out are often connecting with someone who understands Mississippi and its communities, and that's extremely important. We also see high levels of community engagement. Mobile crisis teams are responding to thousands of calls each year, and service delivery continues to expand as teams reach more people across the state. Mississippi now has mobile crisis team coverage in 82 counties, which is a significant accomplishment given the state's size and rural makeup. Another strength that comes up consistently is team functioning. Providers report strong working relationships, mutual respect, and the ability to work well even under pressure. And finally, cross-agency partnerships are a major asset. Mobile teams regularly coordinate with law enforcement, courts, crisis stabilization units, and other partners. So as you look at these strengths, I encourage you to think about what's working well where you are and how those successes can be built on rather than starting from scratch. Next slide. Another core strength of Mississippi's crisis system is that people have someone to talk to day or night. So Mississippi has the 24/7 primary and backup coverage for every county through its two lifeline crisis centers. Contact the crisis line and contact helpline. Together, these centers ensure that calls are answered in state with staff who understand the local context. Contact helpline, located in Columbus, serves as the primary call center. And the crisis is based in Jackson, serves as the primary call center. So most recently, Mississippi has begun expanding text and chat services, which is awesome, with plans to move toward full 24/7 coverage. So this statewide coverage matters because it creates consistency. No matter where someone lives, there's a reliable entry point into the crisis system. Next slide. So the road we are currently on, Mississippi is moving in, and the progress that has been made in the state is significant. Often 15,000 calls to 988 were answered in Mississippi. Over 15,000 calls were answered in Mississippi, along with more than 600 texts and chats. This represents a 14% increase since fiscal year 2023, which is huge. You all deserve a round of applause for those numbers. It's phenomenal. And so, which tells us demand is growing and people are increasingly using this system. Even with growth, the in-state answer rate remains high at around 97%. And that balance between increased volume and strong responsiveness is not easy to maintain. And so when I look at this slide, I see a system that is expanding, adapting, and responding to need while continuing to focus on keeping people connected to help as quickly as possible. Next slide. All right, and so now we'll move into some very specific conversations with insights from the field. And I'll turn this over to Monica at this time.
Thank you, Marilyn. All right. Thank you, Marilyn. So good morning, everyone. It's so nice to be here with you. I was just getting caught up in the chat. You all are asking some really good questions and pointing out some really great things. So just really quickly, my name is Monica Johnson. I am one of the behavioral health managing directors here at HMA. Prior to coming to HMA, I worked at SAMHSA. I was the 988 National Director and Crisis Director. So I'm really happy to be here. And I also came out of state government. So I'm looking at the chat, kind of just remembering some of the things that you guys are doing. It seems like there's a lot of work that has happened and a lot of work that you're still working on. So it's just really interesting to see. So I am going to facilitate a panel discussion, and we're going to start with Brenda Patterson, who has been also in the chat and answering questions along the way. And Brenda, I agree with your answer that you gave. I was just about to chime in there and say maybe it's the backup center. So thank you for that. So we're going to start with Brenda. We're going to have a quick dialogue. Brenda, why don't I go ahead and turn it over to you and let you introduce yourself, and then we'll jump into a little Q&A.
Sure, that sounds great. Good morning, everyone. As mentioned, I'm Brenda Patterson, and I'm the Executive Director for Contact the Crisis Line that's located here in Jackson, Mississippi. I've been Executive Director for 15 years, but prior to that, I was a faithful volunteer since grad school. Prior to coming on board to Contact the Crisis Line as Executive Director, I was an associate psychologist at Hudspeth Regional Center. So I also have been involved with the state system and am licensed as a certified mental health therapist and a licensed IDD therapist through Department of Mental Health. So as on the previous slide, it mentions about how the two main 988 call centers. I think it's also important to note that the 988 Suicide and Crisis Lifeline, it's an evolution of the National Suicide Prevention Lifeline that was established back in 2005 as a network of accredited local helplines across the United States with a single telephone number. The local call centers behind that network are even older. Contact the Crisis Line has been taking calls since 1971, and Contact Helpline in Columbus since 1975. They just celebrated their 50th anniversary. We're both accredited by the International Council for Helplines. And as it's mentioned earlier, too, we have both started taking chat and text, which we're really very excited about. Calls are routed by area code, and the plan is for all calls to be routed through geolocation by sometime in 2026. So that's kind of us in a nutshell.
Thank you, Brenda. Thank you for your leadership in this space. And please express gratitude from me to your team. The work that the crisis counselors do 24/7, 365 days of the year is remarkable. So just want to start with a space of gratitude. All right. So our first question, what are the top three biggest barriers to timely behavioral health crisis response in your region, and what approaches have you helped to address them?
Okay.
Or have
As I
helped you address
mentioned
them?
before, I guess the number one for us, as I mentioned there, the calls are routed by area code. The good news is they're routed by area code. The challenging news is they're forwarded by area code. We receive some calls in which the person is in another state, but their telephone number is a Mississippi area code. My son is a great example. He raised here in Mississippi. He now lives in Connecticut. If he was to call 988, he'd get Contact the Crisis Line here in Mississippi, which may not be as much of a help so far as getting him connected with services. And we also get calls transferred to us by other 988 call centers in which the caller is in Mississippi but has an area code out of state. Maybe they've relocated from Florida, Tennessee, wherever. So we try to keep a list of the local helpline numbers of the other 988 call centers and are able to locate the numbers for the Department of Mental Health Services in each state. But that is a challenge. They're hoping to have geolocation in place sometime in 2026. And what that means is that the calls will be routed based upon where the telephone pings, the closest tower. So that'll make it where it's more local for us. Now, we'll probably still get some of our calls from Tennessee and some of the bordering areas, but it will definitely keep things more local and not have to be trying to transfer people or get them connected to services out of state. So that's probably one of our first big barriers. I think another barrier for us, one of the things that we try to do with that, though, is to try to keep a close abreast with the other call center, 988 call centers. And we do have monthly meetings with the other 988 call centers. And if we see that we're getting an abundance of calls from a particular place, we try to stay connected with them. Another barrier for us is that, as mentioned before, there are 12 regions in Mississippi, and because of the unique makeup of the demographics of each region, it requires our crisis counselors to become familiar with how each region operates. Okay, they're operating within themselves, but we have to learn how each region operates. So, and how they provide mobile crisis. And that's going to be unique to each of the 12. By becoming more familiar with each region through different meetings such as this, and streamlining how each of the region's MCERT teams operates has helped us with that challenge. I guess the third biggest barrier for us is staffing. Okay, that keeping up with the increase of the volume of callers and chat visitors as more and more people are hearing about what 988 is, the convenience of reaching out with 988. That's where our challenge comes, is making sure we have enough staff to meet those needs. And this is especially important when it comes to chat and text. For those that are not as familiar, chat and text takes at least double to triple time as a phone call. A phone call may be, say, 20, 30 minutes. A typical chat's going to be an hour and 30 minutes. It's a very different animal. And but it's very important, especially as it relates to our teens and young adults, because they're more comfortable reaching out through chat and text. So I feel like while it's a challenge, it's also a gold mine. It's our way of being able to reach our teens and young adults. Because as you notice, there was such a big increase in chat and text. By and large, a good 40% of those are people under the age of 25 who would never talk to someone on the telephone, but they will chat and text up a storm. So we're trying to be able to have the staff available to meet the needs of chat and text. Doing some of that, we're trying to do a lot of self-care so far as to reduce burnout. So our trained staff, that they'll stay. So we try to make sure that the chat and text shifts are shorter, that they're not really long, that they have breaks in between, that they don't have back-to-back staffing. And we make use of our wellness room. We've established a wellness room that they've had a difficult chat that's gone on, say, for 2 hours. Take a break. Let the other folks know that you're fixing to take a break, and take a break. And it really does seem to be helping with that. We're also trying to communicate and reach out to our colleges and universities to recruit chat specialists as a way to meet that challenge of needing increased staff. So those are kind of our three main barriers that we have found with the 988 call centers.
Brenda, thank you for sharing those barriers. And I will just say, yeah, they're very common ones. And so you're not alone in this, as everybody is trying to figure out their systems. All of that sounds very familiar to me. And some of the things that you're doing in response to those sound like things that are very positive and things that I would have said, hey, we thought about this or that. I love the self-care and really trying to pay attention to how can you support the helpers that are doing the helping. Have you found anything else to work? Because the staffing component is such a challenge, and I recognize that. Are there other things like do some of this, are all of the crisis counselors in office? Do some of them have like flex schedules where they're working remote? Have you found other things that help with some of the staffing issues?
hmm We have with our dedicated 988 staff. Well, and this is for two reasons. Weather is an interesting thing here in Mississippi. So we use a via telephone system in which it's not a cell phone, but it is an actual telephone like what's here at the crisis line that our
Mhm.
988, some of our 988 dedicated staff have at their home. So if there's inclement weather or just once again working with burnout, is to be able to work 50% of the time at home and 50% of the time here. So no one is
Mhm.
working totally remotely, but no one's working totally here either. So,
Yeah.
and plus that really helps with weather. So if the electricity, we're located in Jackson. If you know anything
Yeah.
about Jackson, yes, either between water and electricity, there's something that might just go down. So this way we can keep on chugging what we've got going on by having that. And the same with our chat,
Yeah.
because yes, we have our computer, we have our cybersecurity all in place, and they do have dedicated um, um, laptops that are specific to do chat, and that's all got all the cybersecurity on it, so they can work from home. Once again, not 24, not 50%,
Mhm.
but no more than that. So it's kind of divided up.
Yeah, and I love the relationship, the coordination with the university in the college system.
hmm
Great idea there. And then I guess I just want to co-sign that when the geo routing is live in this state, that will help address some of the front end barriers that you also talked about, because hopefully you will be able to get people who are actually in the community. And
Absolutely.
wow, I think it's phenomenal that you all are even taking the steps to connect to other states where you have that information. Hopefully, some of
Absolutely.
that will be reduced. So that will be really exciting. So I'll be really happy when you guys get there. All
hmm
right, so let's move to the second question. What have your community's unique needs or characteristics taught you about adjusting how you deliver crisis services to better meet people where they are?
Okay. I think recognizing that Mississippi, as mentioned before, has lots of rural spots and it makes it difficult to help our callers and our chat visitors. So what we have found is that in addition to the active listening, sharing resources, and completing that warm handoff to the regional behavioral health center, that we've trained our crisis counselors to work with safety planning to help our callers help themselves and help keep themselves safe and empower them to be their best advocate.
Yeah.
And once again, let's talk about that safety plan in order to be able to help
Mhm.
keep them safe until they are able to get connected. That seems to
Mhm.
be an important part, especially when I think about some of our people that call. They're hesitant. They're hesitant about the
Yeah.
warm handoff because they're not sure about law enforcement. I'm not sure about all that. I don't want these people at my house. What are they going to do? And I understand that. I
Yeah.
understand that. So to be able to give them the emotional tools so they can help themselves, is one way that we are trying to address that. Safety planning is a huge thing for us, and helping them develop one if they're not familiar, or help them work with the one that they have already in place. So that's
Mhm.
that's one of the unique ways that we are kind of looking at. Also, too, because of the volume of calls, especially chat and text, we're working hard with our staffing to decrease, as I mentioned before, to decrease the burnout by not having the long shifts, having breaks, taking advantage of different opportunities that way. Once again, reaching out to our colleges and universities with their programs that they have on campus,
Mhm.
that seems to help. As I mentioned before, a number of our folks that come to chat and text are under the age of 25, and many of them are in college. So we try to keep a close connection with our universities that have their campus clinics. And so there's several of those we have on speed dial. State, Ole
Yeah.
Miss, and USM, they're on speed dial so far as their clinics and being on campus. So maybe if MCERT cannot reach them, their local, the university clinic can reach them. So that's something else that we have tried to utilize once again to meet our unique needs.
That sounds great. Sounds like you guys are doing really good work. So the last question, can you share a partnership, and you did a little bit of this, formal or informal, that we haven't talked about, that significantly improved crisis services utilization and outcomes in your area and what made it work?
Right. Well, we are very fortunate to be a part of Crisis Connect. And for those that are not as familiar, that is something that is put on by Jamie over at Hines Behavioral Health. And it meets either every other month or every quarterly. And it's a fantastic opportunity to meet with all the team players that come into contact with people that have emotional needs, whether it's going to be AMR, the local clinics, detention centers, and we all meet in one room, and it's fantastic. We all meet in one room and we're able to have an honest conversation about what are some of the barriers that we're challenges that we're each trying to manage, and then ways that we can work through those. What are some ways? Number one, understand what the challenges the others are having, and number two, what can we do to help meet some of those needs? So that is something I have real. Plus, also be involved with some of the other activities that Hines Behavioral Health has, like CIT training. They're very active with that. And as a result of our relationship with Crisis Connect, we are also involved with the CIT training that's offered
Mhm.
every month or so. So I would, that's probably the one of the big partnerships that I am the most pleased with is Crisis Connect. I'd love to see that model being matched in other places as well.
Yeah, thank you so much for sharing all of that insight. Again, sounds like incredible work and just such good perspective. Thank you for the work you do. All right,
It's a team
I'll
effort.
turn it. Yeah, definitely. It's the biggest group project ever. Thank you. So I'll turn it back over to Marilyn. Thank you, Brenda.
All right. Okay. Yes, thank you, Brenda. Thank you, Monica, for sharing that lived experience. I'm sure that we all have so much that we can relate to with what Brenda and Monica were talking about there. The next section we go into is someone to respond. And so when we think about someone to respond, we talk about the mobile crisis teams being available across the state 24/7. I feel like we've covered this slide already. Is that accurate? Give us one moment, please.
Hi, this is Angie. Yeah, I would suggest that given we only have about 15 minutes, that
Okay.
we, go ahead and hear from Jamie, and from Courtney, and get reaction from them and response from the participants.
Okay, sounds great.
Thanks.
I'll turn it over to Jamie.
All right. Well, I'll pick it back up then. So, good afternoon again. Jamie, you want to take a moment to introduce yourself?
Hey, good morning. My name is Jamie Evans. I am the team lead for mobile crisis here at Hines Behavioral Health Service. I also currently serve as the CIT coordinator here at Hines Behavioral Health. I've been with the agency about 16 years now, and I just have a love for mental health, so I just love what I do. And now I've taken a love for crisis response.
All right. Well, thank you for joining us. We're going to ask some questions just similar to what just happened with me and Brenda. So I'll kick us off with what are the top three biggest barriers to timely behavioral health crisis response in your region, and what approaches have you helped to address them?
And so my first is going to be unintentional adversaries. I actually put that in the chat as well. And when I say unintentional adversaries, I'm actually talking about, issues we may have with community partners, and, and unintentional, they're not purpose, they're not done purposely, and I will use for an example that uh, AMR is who we use as far as medical response, and they may have certain protocols or policies saying that they can't transport an individual to the hospital when mobile crisis has been out and said, hey, we feel this individual needs to go, and so it's an issue there, and it's not intentional. It's just their standards and their policies, right? And so we have to understand that it's unintentional, but it's an issue for us because we have someone that we feel that needs a higher level of care. And
Mhm.
we're, trying to secure transportation to get them there if a CIT officer is not available.
Mhm.
Another unintentional adversary would be um, staffing issues with community partners. That trickles down from mobile crisis. If we are responding to an area where Jackson Police Department has a shortage in staff and CIT officers are not available, well, that affects us if we need that officer to transport for us. So in some situations, we may have to wait for an officer to come off another call or to come from a different precinct to assist. So sometimes, we are waiting for hours for someone to assist us with responding.
Wow,
Um,
those were
and,
good
and
ones
so
to
those,
flag. Hmm.
yes, those are just a few of the unintentional adversaries that we have. Another one would be the gap in community knowledge regarding the criteria for what constitutes a mental health emergency. We get
Hmm.
parents to call the crisis line and they say, well, Timmy won't get up and go to school. Well,
Hmm.
that doesn't constitute a mental health emergency. And they may say, well, he's kicking, or he's yelling. And it gets to the point where you have to coach the parent on exactly what a mental health emergency is. So for
Hmm.
me, it's always providing constant knowledge to the community on what defines a mental health emergency.
Very helpful,
And
very
the
good insight. Go ahead.
and number three would be the turnover in crisis response. And the turnover leads to burnout with the staff that
Mm-hmm.
is present or, who is trying to continue to do the work. And if you're short staffed, you find yourself constantly wearing out the staff that you have, and it leads to burnout.
Yeah, thank you. Those are good, really good things to highlight, lift up. And I wrote down the term unintentional adversaries for use later. So thank you for that. The second question was, what are your community's unique needs or characteristics taught you about adjusting how you deliver crisis services to better meet people where they are?
I think it has taught us to be flexible,
Mm-hmm.
um, culturally responsive, and personable.
Mm-hmm.
Because in crisis, we meet people in different situations, from substance-induced psychosis to grief, and we just have to know how to meet an individual where they are in that
Mm-hmm.
moment in crisis. And so I think, and also being mindful of culturally, is this a crisis for them, or what does this look like for them culturally?
Right. All right. And then
So
our last, oh, go ahead, Jody.
no, so I guess for me is again just meeting people where they are, and for me peers are amazing with crisis. I'm always saying that I learned the most from one of the peers who was on the team when I first came to crisis, because just watching her respond and get so personable with the consumers taught me so much.
Yeah, and we have Courtney up next and to lean into that space. So, and I share that sentiment as well. And so just to wrap us up here, can you share a partnership, formal or informal, that has improved crisis services utilization or other outcomes in your area?
So I'm going to have to piggyback off Miss Brenda. I think the Crisis Connect was one of the best things that we could have initiated here at Hines Behavioral Health Service because
Mhm.
it grants the opportunity for all the community partners to come together. And it's not so much a vent session, but just a, a place where we can gain understanding from each other. So, AMR will not feel that I'm just being um, pushy when I'm saying, hey, this
Right.
individual needs to go to the hospital. And at the same token, I need to understand that it's not the fact that they just don't want to do what I'm asking them to do, but they have certain policies that prevent them from doing what I'm asking them to do. So knowing what policies each community partner has been amazing for us, and it has actually worked so well um, with us in pushing crisis response forward in Hinds County.
Yeah, I mean, you just described the power of collaboration. So, and it sounds like it's working well here. So, thank you so much for your insights. All
Thank
right.
you.
Thank you. So, next, we're going to just go ahead and go to Courtney Shelton, our certified peer support specialist. Courtney, you want to do a quick intro and then we can jump into the same discussion from your perspective.
Yes, good morning. I'm so glad to be with you today. I am a peer support specialist and peer bridger at South Mississippi State Hospital. I received my peer support certification through the Mississippi Department of Mental Health in 23 while I was incarcerated at the CWC in Flowood, where I also obtained my forensics peer support certification. Since I've been released from prison in 24 and subsequently began my employment with South Mississippi State Hospital, where I have served for the past 9 months. My role as peer support is to assist individuals with successful transition through the peer bridging process. I've also obtained RAP training and I facilitate those. Being given the opportunity to receive peer support certification and to serve in this professional capacity has been truly life changing, allowing me to transform my lived experience into purposeful and meaningful work in support of others in their recovery journeys. One of the most important things to remember is that peer support puts a face to recovery. We help individuals be seen, heard, and understood during the most vulnerable times in their lives. So, yeah.
Thank you so much for that, Courtney. Thank you for all the things and bringing your story forward and just continuing to pay it forward and helping others. So let's jump into the same set of questions, but from your perspective. So the first question was, again, what are the top three biggest barriers that you, from your perspective, to timely behavioral health crisis response in your region, and what approaches have helped you address them?
Okay, yeah. So some of the barriers we experience is that many individuals in behavioral health crisis are placed in jail while they're waiting for appropriate mental health services. And this delays care. It increases the trauma and it often worsens the symptoms. Another barrier is transportation and placement availability, especially when individuals are ready to step down, but it's the lack of timely options. And then thirdly is the barrier of placement for individuals with intellectual and developmental disabilities. This process has often been very slow and complicated with limited communication between agencies, and it prolongs the hospitalization. But as peer support specialists and peer bridgers, we help address the barriers by sharing our lived experience, strength, and hope. We normalize the crisis experience for them. We advocate for individuals and reduce the fear and stigma. By building the trust, we often help individuals remain engaged while systems work through the delays. We also collaborate closely with the treatment team and the community providers to support smoother transitions whenever possible.
Thank you, Courtney. And you raised some really good barriers there. What have your community's unique needs or characteristics taught you of adjusting how you deliver crisis services to better meet people where they are?
Okay, yeah. So our community has taught us that meeting people where they are requires flexibility, patience, and cultural humility. Many individuals that we serve have experienced repeated trauma, incarceration, homelessness, poverty, and stigma related to mental illness. This means that traditional clinical approaches alone are often not enough. As peers, we lead with connection first. We remind individuals that mental health does not discriminate and that crisis does not define who they are. By being open about our own recovery journeys, we help reduce that fear and shame. We adjust how we communicate by using plain language, validating emotions, and focusing on immediate wellness tools that seem achievable in that moment.
Thank you so much, Courtney. And then last, can you share a partnership, formal or informal, that significantly improved crisis services, utilization, and the outcomes in the area that you are and what made it work?
Yeah, so one partnership that has significantly improved outcomes is the Peer Bridger program. This program allows us to introduce individuals while they are still hospitalized to the peer bridger who will support them in their home community after discharge. This early connection, it builds trust, it reduces the anxiety about discharge, and it increases follow through with appointments and services. What makes this partnership work is consistent support and relationship building. Individuals are not being handed off to a stranger, they are transitioning to someone they already know and trust. Uh, while we do experience challenges when peer bridgers are not available in the catchment areas, the program has still shown strong benefits in engagement and in services following discharge.
Thank you so much, Courtney. Great insight. I've seen outputs from peer bridger programs before, and I think they're amazing programs. So thank you for that. All right.
Thank
All right. I'll turn it back over. Thank you all.
Angie, where do you think we should go here? We have a minute left.
Yes, and we knew we were going to be tight on time this morning, given the rich content that our local collaborators have brought to us today. But we do have more materials on objective 3, and certainly would offer up, because we do want to be mindful of everybody's time this morning, that if you have an opportunity to review those additional slides, I think there might be about 5 of them. And if you have any question about that content, please reach out to the team. We are always happy to connect back with you and answer any questions about the materials that we have provided in any of our trainings. So I would suggest that maybe we handle it that way, Marilyn, moving forward, and that we do our wrap up. And of course, again, like I said, happy to always reach back out and provide you any follow-up information or answer any questions you'd have.
Well, thank everybody for attending today. If you're interested, please join us for the next Crisis Systems Partners convening January the 28th at 10 a.m. to 11 a.m. Central Time. And you can check the DMH website frequently for updates. Thank you to our speakers, presenters today. Thank you, Monica, Angie, Rachel, everyone, HMA team. And we're signing off. Thank you, everybody.